Hello, I'm Captain James Mucciarone, Force Medical Officer for Submarine Forces in the Pacific Fleet. In this presentation, I will describe the first outbreak of COVID-19 on a U.S. Navy submarine. The presentation will start with background information, then explain the methods for gathering the data, present the data, discuss results of the data, then make some recommendations for how to handle a similar case in the future. I have no financial disclosures. The opinions expressed are my own and do not represent the Department of Defense, the Department of the Navy, the Pacific Fleet, or Commander of Submarine Forces Pacific. These are the learning outcomes. And this is how you may claim continuing education credit. From late March to May of 2020, a submarine on a port call in Pearl Harbor, Hawaii, had an outbreak of COVID-19. This was the first COVID-19 outbreak on a U.S. Navy submarine. Eventually, 12 of the 134 crew members tested positive for coronavirus. That the submarine was on a port call is significant because all members of the crew were living on board. The dates are significant because this was occurring at the same time as the aircraft carrier Theodore Roosevelt was having an outbreak of COVID-19 in Guam. In Pearl Harbor, we had access to much of the information and the lessons that were being learned on the Theodore Roosevelt. There have been larger outbreaks of COVID-19 since last spring, but a look back at how this first outbreak was handled can be informative for how to handle outbreaks of COVID-19 or other infectious diseases in the future. A final point concerning submarines. U.S. Navy submarines have a nuclear reactor on board. The submarine must be maintained by a crew that is qualified for that specific submarine. It is not an option to take a crew off of the submarine and put another crew on there. Some background information about submarines. In general terms, the U.S. Navy has two classes of submarines: SSNs, also called attack boats, and SSBNs that carry ballistic missiles. SSNs measure approximately 110 meters long by 10 meters wide. SSBNs are approximately 130 meters long by 15 meters wide. The crews are approximately 150 to 170 sailors, respectively. If you look at the image, you'll see that the back half of the submarine is largely occupied by the propulsion plant. The nose of the submarine is occupied by the sonar dome. This means that the majority of the crew live, work, eat, and sleep in a space that measures roughly 50 meters by 10 meters and is spread out over 3 decks. The term congregate environment usually applies to dormitories and prisons, but it is appropriate in this case as well. The air on a submarine is recirculated. There are reports of disease outbreaks on other ships where the proximity to vents was associated with infection. However, looking at diagrams of the ventilation systems and locations of the infected sailors, proximity to the vents did not appear to contribute to this or any other outbreak on a submarine. A brief review of the virus. Severe acute respiratory syndrome coronavirus 2 is the virus that causes coronavirus disease 2019. The virus is approximately 100 nanometers in diameter. When a virion binds to a cell, it takes approximately 10 minutes to enter the cell and begin replication. In 10 hours, over 1,000 progeny will be released. For symptomatic cases, the mean incubation period is 5 days. For mild cases, the infection will run its course in approximately 14 days. More severe cases may last 6 weeks or longer. The reproduction number, sometimes referred to as R0, is the number that can be infected by one person. For R0 to be accurate, the population must be naive to the virus and no countermeasures can be in place. An R0 greater than 1 means the disease is expanding. The early literature from China reported a reproduction number of 2.6, with some reports claiming up to 4. For comparison, the reproduction number for measles is approximately 12, and the reproduction number for mumps is approximately 10. With precautions in place, the R0 for coronavirus appears to be closer to 1.4, but by definition, R0 cannot be calculated when precautions are in place. I bring this up to point out that even with countermeasures in place, the reproduction number is greater than 1, so the virus continues to expand. Some background about transmission. The virus is spread by droplets, aerosol, and surface contacts. The primary means of spread appears to be droplets, meaning a virion gets released from the carrier surrounded by liquid. Droplets are categorized as large and small. Large droplets, greater than 5 micrometers, fall to surfaces. Small droplets, less than 5 micrometers, can remain suspended in the air and be inhaled. When the droplets come in contact with mucous membranes, the virus can infect the next person. Virions that are released but not surrounded by liquid are aerosolized, meaning they are traveling freely in the air. Regarding surface contacts, when the droplets land on surfaces, a person can come along and touch those surfaces and get the virus on their hands. If the person then rubs his eyes or his nose or eats something with their hands, they may infect themselves. In the beginning of the pandemic, there was a lot of focus on surface contacts. In the more recent literature, it does not appear to be as significant a means of spread as it was considered in the early phases of the pandemic. The purpose of this presentation is to review the details of this outbreak so others who work in congregate environments and may encounter similar situations can be better prepared. All patient information was gathered from the Submarine's patient log or ComSubPac patient reports. All diagnoses were confirmed by reverse transcriptase polymerase chain reaction. No cases were based on clinical diagnosis. Concerning laboratory testing, samples were collected using nasopharyngeal swabs, which were immediately added to viral transport medium. They were accessioned at Navy Medical Readiness and Training Command, Pearl Harbor, and then transported to Tripler Army Medical Center for processing and analysis using the CDC Emergency Use Authorization Assay and Thermo Fisher ABI 7500. Personal emails were also used to confirm some dates and policies. The Gordis textbook of epidemiology says for an outbreak, one must identify who, when, and where. For this outbreak, it was the crew of a submarine. There were 12 cases out of a crew of 134 people. It occurred from March to May of 2020 in Pearl Harbor, Hawaii. 12 cases were diagnosed from March 28th through April 17th of 2020. All cases were enlisted sailors. Their age range was from 19 to 36 years old, with a mean of 28 years old. 4 females and 8 males became infected. The crew was approximately 20% female, so proportionately this is a slightly higher attack rate for females. However, it's not statistically significant. 4 of the patients were symptomatic at their time of diagnosis. 2 of the patients were pre-symptomatic, and 6 of the patients remained asymptomatic for the entire time. Disease severity was mild to moderate, with 2 of the patients going to the emergency room for further evaluations, but none of the patients were admitted to the hospital. None of the patients had significant comorbidities, and the attack rate for the crew was 9.0%. All of these findings were consistent with what was being observed on the Theodore Roosevelt at the same time. I will use this slide to tell the story. On Sunday, March 22nd, a single sailor took a public bus from Pearl Harbor to Waikiki Beach, approximately a 30-minute bus ride. The sailor spent the afternoon on the beach and then took the public bus back to Pearl Harbor. On the ride back, the story is that another passenger on the bus was coughing incessantly. On Thursday, March 26th, the sailor who had ridden the bus developed influenza-like illness. He presented a sick call on Friday, March 27th, and was sent to be tested. Now, this sailor was relatively new on the submarine, and he was trying to get qualified. That means that when he was not on watch doing his job, he was moving up and down the submarine, talking to people, interviewing them, and trying to learn what they did. The initial close contact investigation for this sailor identified 70 people that he had been in close contact with. Fortunately, with more rigor, that number came down to 27 people that he had been within 6 feet of for greater than 15 minutes. That sailor's positive test result came back on Saturday, March 28th. On Sunday, March 29th, 3 more sailors presented with influenza-like illness. Now, these 3 sailors were sick. All of them had cough, shortness of breath, and fever. 2 of the sailors were close contacts of the index case, but 1 of them was not. Their test results came back on Monday, March the 30th, and they were all 3 of them were positive. In other news, on Tuesday, March the 31st, the commanding officer of the Teddy Roosevelt, Captain Crozier, his letter went public about all the gloom that was occurring over on the TR. On Wednesday, April 1st, a phone call was held with representatives from the Submarine, Tripler Army Medical Center, NMRTC Pearl Harbor, ComSubPac, and the other parent commands for that submarine. And a plan was created in which the non-infected crew members of the submarine would be divided into 2 cohorts, or 2 watch sections, of approximately 50 watchstanders per section. At this time, there was concern about fatigue for the watchstanders. No one was really sure how long somebody could safely stand watch in a reduced watch section on board the submarine. So the original plan was to swap out the crews at 4 days. Fortunately, once the crews started standing their watches, they realized that they could push a little bit farther, and ultimately they ended up doing 8 days as a reduced watch section. Another concern at this time was the number of tests that were being used. Remember, this was early in the pandemic, and tests were in short supply. In Pearl Harbor, nobody had attempted a mass testing of a crew of a vessel like this yet. So the plan was to test Duty Section 1 as they came off the submarine, and then test Duty Section 2 when they got released from the submarine. On Friday, April 3rd, Duty Section 1 was moved from the submarine, and RT-PCR testing was conducted on the pier, and then that section was moved into the barracks into a quarantine status, 1 person per room, 1 bathroom. Since no one had symptoms coming off the submarine, all of them, we expected everyone to be negative. The tests identified 5 asymptomatic positives in that cohort. As I said, Duty Section 2 was doing well on board the submarine, and so based on the 5 positive tests, the decision was made to retest Duty Section 1 before they manned the submarine to ensure that we were not putting the virus back on board the submarine. On Friday, April 10th, Duty Section 1 had their second RT-PCR test, which identified one more asymptomatic positive. On Saturday, April 11th, Duty Section 1 took over the submarine and Duty Section 2 went directly into a quarantine status. On the 17th of April, so 14 days after taking the watch or after being restricted in movement for 14 days, Duty Section 2 had their RT-PCR testing, and this identified 2 asymptomatic positives. Those 2 sailors immediately went into isolation status. And this started the phase of basically meeting return to work criteria. And none of these sailors met return to work criteria, or many of the sailors did not meet return to work criteria for a long amount of time. The last sailor ultimately met RTW criteria around the 27th of May. This chart is presented as another way to view the cases. Cases in light blue presented with symptoms. All others were asymptomatic at the time of diagnosis. On this slide, it is important to point out the number of days in restricted movement. Only the index case and case number 4 were released in 14 days. All others spent significantly more than 14 days in isolation, with cases 2, 3, 6, and 8 spending near 60 days in restricted movement. The other thing to point out on this chart is case number 3. Case number 3 is what we would now call a long hauler. She had a waxing and waning illness with several trips to the emergency room for evaluation. She eventually met return to work criteria, but by then the medication she was on disqualified her from submarine duty, and she was returned home. She was returned to her home port via air. This slide shows how the crew was divided into 4 cohorts. On March 27th, the index case was moved into quarantine barracks. On March 28th, when the test came back positive, he was moved into isolation, and 29 close contacts were moved into the quarantine barracks. On March the 30th, the 3 new symptomatic cases were moved into isolation. Cases 2 and 4 were close contacts of the index case, but case 3 was not. That case was de novo out of the crew on the submarine. On April 3rd, Duty Section 1 was tested, and the 5 positive cases went into isolation. The remainder of the crew moved into the Navy Gateway Inn and Suites in a quarantine status. On April the 10th, Duty Section 1 was tested for the second time, and one more asymptomatic case was identified and moved into isolation. On April 11th, the Duty Section swapped out, with Duty Section 1 going onto the submarine and Duty Section 2 moving into quarantine in the NGIS. Duty Section 2 tested out on April 17th, and the last 2 asymptomatic positives were identified and moved into isolation. On April 18th, Duty Section 2 returned to the submarine. Regarding sanitization, as soon as the index case left the submarine, the cleaning began. A deep clean was performed on Saturday, March the 28th, focusing on the berthing, workstations, and transit areas. With 3 more sick sailors on Sunday the 29th, a second deep clean was conducted on Monday the 30th. The best cleaning agent was dilute bleach solution. The dilute bleach is virucidal and not as corrosive to equipment on the sub as other cleaning agents. After March the 30th, whole ship cleanings were conducted twice a day in the morning and night, with emphasis on high-touch surfaces, such as railings, door handles, and tables. Common areas were also emphasized to include the galley and heads. In addition to the twice-a-day daily cleanings, crews were cleaning in and out of their watch sections, meaning that the off-going watch standers would wipe down their equipment before departing, and the oncoming watch standers would wipe down the equipment before taking the watch. Dilute bleach was primarily used for the daily cleanings, and hypochlorite wipes, more commonly called Clorox wipes or Lysol wipes, were used to clean in and out of the watch stations. For personal protective equipment, one must remember this was early in the pandemic. When the first case was diagnosed, there were 11 N95 respirators on board the submarine and no other face coverings. The hospitals were directed to tightly control their supplies in preparation for the large number of patients and subsequent supply shortfalls that they were expecting. Locally, Home Depot, Lowe's, other medical vendors, and all the commercial vendors were sold out of their respirators and face masks. There were no other supplies on the other local submarines, so cross-decking was not an option. Essentially, there was no personal protective equipment available to give to these sailors on this submarine. The sailors themselves took to wrapping t-shirts around their faces, which at the time was not recommended, but on April the 1st, Dr. Fauci came out and said that cloth face coverings were beneficial. On April the 1st, the commanding officer directed that all hands on the submarine would wear face masks and latex gloves at all times when they were on board. On April the 2nd, a local hospital was able to donate several hundred surgical face masks that were expiring. For testing, all tests were conducted with reverse transcriptase polymerase chain reaction. On March the 27th, 4 patients actually presented with influenza-like illness, but only the index case tested positive. The 3 symptomatic cases were tested on March the 29th. On the 31st of March, 3 more sailors presented with influenza-like illness, but all 3 sailors tested negative, and they remained negative throughout the various testing evolutions over the next few weeks. As previously mentioned, Duty Section 1 was tested on April the 3rd with 5 positives, and their second test was conducted on April the 10th with 1 more positive. Duty Section 2 tested on April the 17th with 2 asymptomatic positives identified in that test. There were persistent positives in this group of sailors, and so viral cultures were collected on the 5th of May, and 1 culture was collected on the 12th of May to help figure out what was going on with these sailors. All of the viral cultures reported back no growth. Serology testing was not used for this submarine crew. The original return to work criteria was based on time and symptoms. The criteria was 14 days since the onset of symptoms improving for 3 days, and no fever. At 14 days, cases 1 and 2 had no symptoms and they returned to work. Cases 3 and 4 had improving symptoms and were released from isolation. However, when they got to the pier, it was obvious that cases 3 and 4 were too weak to return to work. With their shortness of breath and fatigue, they were not capable of climbing up and down ladders or going into the submarine. So they were placed in a berthing barge that was tied up near the submarine. As previously mentioned, case 3 was a long hauler. She went to the emergency room 3 separate times for evaluations, and she tested positive for COVID each time she visited. This was one of the first cases we saw of a persistently positive patient. By mid-April, return to work became based on testing. Initially, in addition to the clinical criteria, a single negative test was needed to return to the ship. In May, 2 negative tests, called the double negative test out, became the requirement. Once this happened, it was difficult for many of the sailors to get back to work. An example of this is Case 2. In April, Case 2 met return to work criteria based on clinical symptoms. He returned to work and was actually on the submarine when Case 3 tested positive for the first time in the emergency room, and the requirement came out for a negative test to return to work. Based on that, we took him off the submarine and tested him, and his test came back positive. He was returned to isolation, and he was tested for every 48 to 96 hours for the next few weeks. He remained positive until approximately May the 10th, when he got his first negative test. Unfortunately for him, the next day, the requirement for the double negative test came out. And so when he was sent for his second test, he remained positive, or he came back positive again. And case number 2 just toggled between positive and negative for the next several weeks until the criteria for testing was finally removed. Moving into the discussion, immediate quarantine and isolation appears to have been one of the best things that was done for this crew. Specifically, getting the infected patients placed in isolation and their close contacts into quarantine barracks created space on the submarine so the rest of the crew was able to spread out a little bit more. After March the 30th, there were no clusters of cases. The remainder of the positive cases came from group testing, and all of those cases were asymptomatic when diagnosed. That there was only one wave of infection on this submarine is in contrast to the reports that came out from the Theodore Roosevelt and eventually the USS Kidd, which had 2 and 3 waves of infections. The obvious difference between these cases was that this submarine was in port and had the ability to rapidly get the sailors off the platform, while those other vessels were not able to do that. Looking at this photo, you can see what a challenge it is to contain a respiratory illness in this environment. The watchstanders are sitting nearly shoulder to shoulder. They're talking, they're touching the equipment, and there are more people standing over them breathing, essentially right over their heads. Regarding personal protective equipment, in retrospect, sailors wrapping cloths around their faces likely did slow the spread of the virus. The medical supply list has been updated, so submarines are now carrying enough N95 respirators for the medical department representative and medical attendants, and they are also carrying surgical masks, which can be placed on symptomatic patients. The latex gloves were worn on the submarine primarily because they were abundantly available. Their impact is unknown. If worn properly, gloves can be beneficial, but proper washing the hands will likely have the same effect. Concerning sanitization, we have reviewed how often the sailors were cleaning the submarine. Dilute bleach and hypochlorite wipes are virucidal, and they remain the cleaning agents of choice. Some recent studies suggest that surface contact is not a significant source of spreading the disease. However, the cleaning habits that the crew established are important in that it gives them an action to feel like they're doing something to stop the spread of the virus, and it also keeps them aware that they should not be conducting business as usual. So I'm a proponent of continuing the surface cleaning habits that they have established. For testing, RT-PCR was the only reliable test available, and that is what we used. This was early in the pandemic, so testing supplies were limited, and this was one of the first times an entire crew was tested in Pearl Harbor. The tests were successful largely due to the professionalism of the teams from NMRTC Pearl Harbor and Tripler Army Medical Center. This photo shows the second test of Duty Section 1. The team from NMRTC Pearl Harbor conducted a site visit the day before, identified where their testing stations were going to be set up. They arrived early on test day, set up their stations, and were ready to go at the appointed hour. And they moved efficiently throughout the entire process, moving the sailors on through their testing. The team at Tripler was equally professional. They were very accommodating in providing test materials, and they turned the results around in near record time. Frequently, we would have an entire batch completed within 6 to 12 hours, which enabled the line officers to make decisions based on the information. And while I have not mentioned them previously, Navy Environmental and Preventive Medicine Unit 6 had personnel involved in this process throughout. They were key in tracing close contacts, and they were also key in getting the testing set up. Other forms of testing were available, but they were not reliable. Viral cultures took too long to come back, and nobody was really sure what to do with the results when we received them. Viral cultures were always negative, it seemed, and so they were not a good tool to make decisions off of. Serology was another modality that was available. At the time, it was also expensive, and then, as it is now, nobody was really sure what to do with the results of the serology tests either. For recommendations, I tried to take guidance and distill it down to very simple instructions. These recommendations are not earth-shattering. They're simple, but they have proven to be successful. For future outbreaks, we recommend isolation, quarantine, sanitization, and testing. Isolation and quarantine remain some of the best methods to stop the spread of a virus. If on shore, we recommend dividing the crew into 4 sections. Positive cases go to isolation immediately. Close contacts of the positive cases go to quarantine. And as a reminder, on shore, isolation and quarantine should be one person in one room with one bathroom. The caretaker or dirty crew will stay on board the submarine or whatever vessel you have. For the submarines, we've discovered approximately 1/3 of the crew is the right size for a caretaker crew. Experience has shown that the watchstanders do not fatigue as much as we expected them to. While on the submarine, we recommend cohorting as much as possible, with the same people eating, berthing, and working together. Cohorts should not intermingle. This way, if one person is infected, they'll spread it to the cohort, but hopefully not to the rest of the crew. The 4th section is the off crew, or the clean crew, and they will move into a quarantine status. If rooms are available, we recommend they stay on base, either in the barracks or some other form of base housing. This prevents the spread of the infection out into the community. If nothing is available on base, a hotel can be rented. Also, we recommend against letting these crew members go to their houses, as this is another means for the spread of the infection into the community. For these sailors who end up in the quarantine status, they're going to need to be fed, and they're going to need their laundry to be done. So plans need to be made to provide this. And then a huge morale issue is access to the internet. So whenever possible, this should be provided as well. For personal protective equipment, the N95 respirator protects the person that is wearing the mask. It must be fitted properly, and it should be used by the medical department representative and other medical attendants. Surgical masks are designed to keep secretions close to the body. They should be used for symptomatic patients or patients under investigation. Cloth masks are the next best available, and they're reasonable for everyone else in the crew. Small spaces are places where the virus appears to be spreading, And so PPE should be worn when people are in these spaces. And in particular, leaders need to make sure that that is happening. For sanitization, dilute bleach remains the cleaning agent of choice. Hypochlorite wipes are also approved for submarines and are reasonable. It is good practice to wash in and out of the wash stations to make sure those high-touch surfaces do not become vectors. Common areas such as the galley and heads are other areas of risk. And they need to be cleaned thoroughly and regularly. In addition, meal hours are something that can be modified. We recommend extending the meal hours, therefore less people are eating at the same time, and that provides time to clean the tables between diners. Regarding testing, RT-PCR remains the gold standard for the foreseeable future. When an outbreak is suspected, we recommend testing the symptomatic cases immediately. When those results come back, close contacts of the positive cases should be tested as soon as possible. The caretaker crew should also be tested as soon as possible in case there is an infection in that crew that'll prevent the one infection from becoming 30 or 40 over time. For those that are going to be living off hull, they should be moving into a quarantine status by themselves, so testing them immediately is not a priority. We recommend waiting one full incubation period before testing these personnel, as this gives a reasonable chance of catching the virus, as well as gives the line commanders enough time to react if the infection is more widespread. They can call in extra crews or adjust their timelines accordingly. For surveillance testing, pooling of up to 5 samples has been successful using the biofires. We are not doing this on the submarines, but it is my understanding that some of the surface vessels are looking at this. Biofire testing is not recommended for an entire crew test, and that it takes 1 test per hour using the biofires, and the amount of time just becomes excessive. The testing technologies are changing rapidly. In particular, antigen tests are coming out, and new testing algorithms are being figured out and how to use these tests. As mentioned on the previous slide, antigen testing is evolving at this time. All of the submarines in the Pacific are now carrying antigen testing capabilities on board. Antigen tests are a cheap, rapid way to get a diagnosis, and they are particularly useful in the underway setting. And they can give the corpsman and commanding officer confidence in the decisions that they're making while they're underway. At the time I'm recording this presentation, there are no protocols for surveillance testing using the antigen tests. However, by the time you watch this presentation, it is possible that protocols will be put out. In summary, this presentation has reviewed the first COVID-19 outbreak on a U.S. Navy submarine. Data was gathered from logs and patient reports, and all cases were diagnosed using RT-PCR testing. This outbreak had 1 wave which infected 12 people. Isolation and quarantine appeared to be the best methods to stop the spread of the infection. Personal protective equipment and proper cleaning were also important. RT-PCR testing remains the gold standard for the diagnosis of COVID-19, but antigen testing is evolving, and anyone involved in these cases needs to stay abreast of what's going on with antigen testing. Virology and serology are interesting, but they are not particularly useful in the operational setting at this time. Too many people contributed information that's been compiled into this brief to identify individually, but I would like to thank specifically Lieutenant Commander Mike Zendel, PhD at the Naval Health Research Center, for his advice and guidance in preparing the presentation, as well as Captain Chris Sears, the 7th Fleet Surgeon. I'd also like to thank Captain Mike McGinnis, PAC Fleet Surgeon, and Captain Lisa Pierce, who at the time was assigned to NEPMU 6, for their advice and guidance in handling the outbreak. Thank you for listening to this presentation, and I look forward to your questions.